Hello and good evening. We are coming live from TENRI Group of Hospitals, Majimbo, and today we are talking about occupational therapy in pediatrics. And today we have Dr. who is here with us. You can introduce yourself to the viewers so that they can know you more.
I'm Susan Jerry, an occupational therapist at Ebu Children Hospital, currently working in Majimbo branch.
Okay.
Hey.
Karibu sana to the show. Today we will talk about occupational therapy and mainly in children because that is what you really do here at TENRI. And we offer occupational therapy services every day, right? Yeah. From Monday to Sunday, from 8 a.m. to 5 p.m. So you can come over if you have a child who needs occupational therapy or they need some management on occupational. You can come over, see Susan, who will be able to check on your child and everything shall be well. So you can also continue talking to us and asking Dr. all the questions that you have here on Talk to Your Doctor show, or you can also write to us on 0723 386 706 and also on our social media pages because we are live and she will be answering all the questions that you have. So today, Dr. we start with what is occupational therapy because so many people do not know.
Occupational therapy is a health profession which is concerned with promoting health and well-being of people through occupations. We say we use therapeutic techniques to improve, rehabilitate and maintain the ability of a patient to perform a task or daily task.
So that means so many people that you attend to, they are not able to perform a certain task or they have a certain problem.
Yeah, they have a certain condition which has to affect their performance in their daily activities of living.
Okay. Yeah. Okay. So what are the areas of occupational therapy?
Yeah, we have 3 areas of occupational therapy. Number 1, we have, which we are going to talk about, occupational therapy in pediatric. Number 2, we have occupational therapy in physical dysfunction. Occupational therapy in mental health or psychiatry.
So someone who has some psych problem needs some occupational therapy. Okay. So today we talk about this one, the occupational therapy in pediatric. So tell us about this.
Occupational therapy in pediatric, this is whereby an OT work with kids who has delayed in motor skills, sensory processing disorders, or any other coordination issues.
You just talked about so many medical terms. So can you explain the medical terms you've talked about, like the sensory something?
When I talk about the delayed motor skills, I'm talking about delayed milestone. We have children who has delayed milestone, secondary to many conditions which we are going to talk about as we move on. Like when I talk about delayed milestone, for example, a child is past 6 months and cannot be able to hold his or her neck, or a child is past 1 year, cannot sit on her own without support. We say that child has delayed milestone. That's what I mean when I say a child with delayed motor skills. When we come to sensory processing disorders, this is where we include conditions like autism, ADHD. Now the occupational therapist doesn't manage autism, but we manage now the symptoms of these conditions.
Is there a time whereby you maybe managed a child who has not been able to talk for a long time, and then after some therapy, this child is able to talk?
Many of them. For example, every child who comes to us with a delayed milestone also has to delay speech, because also speech we classify it under milestone. So after we have managed this child, the child has been able to walk. Now we assess the speech. If the child cannot be able to speak, we ask the mother to bring this child to undergo speech therapy, and this child talks and joins schools.
Nice one. So parents with children who are not talking, they should come over and they shouldn't be worried that my child isn't talking. They can come over and this thing can be treated. So we can talk about the condition managed by an occupational therapist in pediatric. What are these conditions that you manage here?
As I said earlier, we manage those delayed milestones. So delayed milestones are caused by many conditions. The most common one, number 1, is leakage, which is most common nowadays. Leakage is whereby we say a child has low calcium or vitamin D levels in the body, and we know that calcium, vitamin D, they are the things that gives the bones, they make the bones strong so that the child can be able to achieve milestone. So when they are low or a child has vitamin D deficiency, we say this child has ricket.
Yes.
So this ricket, one symptoms of ricket is delayed milestone. So we manage now not the ricket, but we manage the delayed milestone, the symptoms of ricket.
Yeah.
Another condition, the most common is failure to thrive. Malnutrition, we find these children who are not, the child is 10 months, the kilos are low, the child, if you look at the child is small than the age, we say that the patient has failure to thrive. Another thing is prematurity. When a child is born before that 7 or earlier, before that 7 weeks of pregnancy or earlier, we say that a child, we call it prematurity. So most of them later, they have that delayed milestone. So we ask mothers, like in our hospital, after delivery, we follow up this patient so that we can ensure the milestone, the child is achieving milestone well. Another condition, most common one, is we call it cerebral palsy. Cerebral palsy is a brain damage which can occur during, before, during, and a few minutes after delivery, where the brain lacks enough oxygen. Now when the child is born, the child cannot be able to cry. So maybe the brain is damaged, now the child gets cerebral palsy. Now this cerebral palsy, when it affects the brain, it also affects the coordination of muscles, movements. Now the child gets delayed milestone. Then that's where an OT comes in. Now there are the others, which are not most common. Like we have hydrocephalus, where you have a child who has a big head. We have microcephaly, we find a child with small head. We have Down syndrome. Now those are not, they are rare, they are not most common.
Okay. So I know you've been in this profession for long, and you didn't tell us for how long. So have you maybe managed a child who has cerebral palsy and they grew up and they became normal?
Yes. When it comes to cerebral palsy, it also depends with the time that you started the therapy. If you start therapy early, the progress is good. But if you come late, like when the child is 1 year, yes, the child will improve, but it will be slow. But we advise, like when, like here in our hospital, when a child is born with those, maybe child born maybe earlier or with those, with those but asphyxia, we put them in our NBU unit. Now, me as occupational therapy, I'm always there to follow up on that child to make sure the baby is able to breastfeed well. I also check on their reflexes to make sure that when the mother is going home with the child, I also train the mother how the baby is supposed to achieve the milestone. Now, when the mother notices that there is a delay in milestone, now our patient comes back. Now we are able to start this patient on therapy early, and the outcome is good.
So that's the reason why I've not been able, for the longest time, you don't see so many children when they are big with cerebral palsy, because long time ago you'd see even grown-ups with that problem, because now there is this therapy that is being done to them. So we can maybe talk about the causes of delayed development milestones.
Number one is that we have said the malnutrition, we have said ricket, we have said the prematurity, we have said the most common, there are those 3, then the others are Down syndrome, hydrocephalus, meningitis, but mostly we find meningitis happens like after a child is born, grows well, it reaches somewhere the child gets infection of the meninges, now get the meningitis. If it is not managed early, now it causes the child now to regress in milestone. So we call it regressed milestone, not the delayed milestone.
Okay, so at what age is the baby supposed to achieve neck control, sitting, standing, walking?
A nice question. We say they are called developmental milestone. we say by 3 months, a child is supposed to have achieved neck control. The neck is not falling at 3 months. The baby is stable. By 7 months, a child can be able to sit well without support and play with the toys without falling. Now, and at 7 months, still this baby, you can make him or her stand and can be able to weight bear on the legs well. Yeah. Then we say by 1 year, 1 and 3 months, now this child can be able to walk alone without support. So if you see a child 1 year past 6 months and cannot sit, cannot walk, so that's, you're supposed to learn very fast.
So is there a possibility whereby maybe a child comes at 2 years, they're not able to walk, their neck is falling down, like it's not stable, their hands maybe cannot function well. How do you deal with such a child at 2 years?
2 years, at this first you explain to the mother, already we are late here. The mother has come when the condition has prolonged. So first you assess the child, you have said this child has no neck control, the hands are not working, the baby cannot sit. So after assessing the child as occupational therapist, we prioritize our treatment plan. So number 1, neck control comes first. We do the whole therapy, but I point my point at neck control. This child must first achieve neck control so that now we can move to sitting. The child cannot sit if we have not sit if we have not achieved neck control. So we work on the neck control. There are certain equipment that we use, there are certain, as I said, therapeutic activity that we use so that we can achieve this. Then after that we go to sitting, we train whether it is balance, if there is deformity of the back, we work on it. There are some appliances that we give. Even when we come to the legs, we assess if the legs are okay, any deformity, we correct it, and we make sure the child is able to walk.
So parents shouldn't be worried, because I was seeing a long time ago when someone was like, nimepata mtoto akona shida, so people are very much worried about those problems. But it's good now you are able to maintain them. So what are the conditions that causes delayed speech? And also especially in children?
Delayed speech, number 1, as I said earlier, if a child has a delayed milestone, also speech delay. So number 1 cause is delayed milestone. That child will delay in speech. Another conditions, we classify them under sensory processing disorders. These are conditions like autism, ADHD, and mental retardation. So when we talk about autism, these are, we call them neurodevelopmental conditions, whereby it affects the patient, how the patient interact with others, how the patient behave, communicate. Like in autism, the patient has no eye contact, they like playing alone, you see the socialization interaction is affected. You also see other behaviors, abnormal behaviors, which you cannot see to another child. And these behaviors, you assess them from the age of 2 years. If you see a child is 2 years, cannot maintain eye contact, the child is not talking, the child like staying alone, the child has, we call them tantrums, like biting others with teeth, beating other children. We say that you are supposed to bring that child to us so that we can assess, whether there is this autism. Now there is another one, ADHD, attention deficit hyperactive disorder. This is whereby now this child, they are so hyper, we say their brain is always on the move. This child don't know how to sit still. They're always on the move, jumping up and down.
When you go stay at one place.
When you go with this child to a supermarket, ukimwachilia kidogo unaweza mpoteza. So, and when these babies, they also don't know how to interact with others. It also affects communication, because we say the cognitive skills, their cognitive skills is affected. So the also speech is affected, because this child cannot concentrate. There's no attention, so that you can train him or her the speech. Another one is mental retardation. Those babies who are, their IQ is low.
So a child comes with ADHD to you, and how is the process you take the child through so that they can be maybe normal?
Like ADHD, we manage them at this, we call this model sensory integration. At the sensory integration, we have a certain room for these kids. For example, for the hyperactive babies, we have a dark room, which is very safe. Number one, when a child comes so hyper, we close them there, they cool down first. So like 30 minutes, then you bring out the child now is cool, you can engage. You know, the energy is too much. There's something we call tampering. We jump with them, you make the baby jump until the energy goes down. Now you can be able to go to some activity, like table activities. You see, you are training cognitive skills, like concentration, attention. So we go to table activities, among other activities, to make this baby concentrate, to bring back improve his or her cognitive skills, so that this child, when we are managing them, we look this at a short and long term objective. Long objective, like this child can be able to cope in school environment.
So for how long does it take?
It depends. It depends with the condition. There are those who have both autism and ADHD. There are the one who has one, so it depends. Some 2 months, then you find that the child has improved.
So if someone asks such a child, they can bring them?
Yes.
Okay, nice one. So what, we go to the next question that I have here. What are skeletal deformities managed by an OT?
Yeah, wow. At occupational therapy, we also manage skeletal deformities. Like, for example, number one, we have bow legs. Bow legs, where a child, you start seeing a child, all of a sudden the legs are bowing. Yeah, and these are the symptoms of ricket. We said when the ricket is the deficiency of vitamin D in our bodies, which makes our bones strong. So when the bone is weak, when the child starts weight bearing, you find the legs becomes bow. So we call it bow legs. That is number one. Skeletal deformity that we manage very well with some appliances. Number two, we collect something we call knocked knees. Now, when the child is walking, the knees are touching each other. And you hear the mother telling you that when the child runs, the child falls a lot because the knees are touching each other. Another thing, they are like the back deformities, like we have like something we call scoliosis. You find that the child is bending, the back is bending, a deformity. Sana sana utaiona kwa watoto wa cerebral palsy, also in ricket also. We manage them. We have other things which are now mostly common, like flat foot. Those people who have flat foot, they walk where the leg beds. Unasikia watu wanasema viatu zao zinaisha huku katikati, the flat foot. We also manage that. And when it comes to these skeletal deformities, we tell mothers, if you see as early as 1 year, if you notice a child has these skeletal deformities, it is better you learn early. So that it can take shorter time to be managed.
We have another condition. The club foot?
Yes. Even under the skeletal deformities, we also manage club foot. These are mostly diagnosed after delivery. Like, for example, here our nurses always call me when they see a child born with legs like pointing each other, bedding. They call me, we manage through casting, something we call polyceti method, where we do serial casting, tunamfunga na plaster, tukiwa tumeka hiyo mguu vizuri. Then after 2 weeks, the child comes, we open, we reassess, then we see.
There is even grown-ups or big children, which maybe have legs, like they look upside down. Okay, they can walk very well, but you see the legs are not like straight, stable.
The legs,
maybe from the back, they have bent, they are bending. So do you manage that condition even when someone is maybe a grown up? Although
we ask the patient to come also, we do, if we find the big children, we also incorporate our orthopedic surgeon. So we say medicine is multidisciplinary. So we involve our orthopedic surgeon, so they also help us, so that we can help the patient.
Nice one. And are these conditions, patients who are maybe over 18 years coming with these conditions which were not treated when they were young?
Most of them, they fear to come, but it is good. I would request, it is good you come, so that we can assist you.
And it's possible for them to be now
you can be assisted.
Okay. Right. So what is the right time to start therapy session for a patient?
The right time, immediately you detect a problem. I always say and tell patients, when you see your child has a problem, don't ask neighbor, don't ask anybody out there. Please come to the hospital. In our hospital, we have pediatricians. Come, ask, and the pediatrician will refer you to the right person. And when you come early, I said the outcome is always good. Don't wait for the condition to be worse.
Wow, nice. I'm checking on the feedback here, and I can see most people. There's someone by the name Brenda Wanjera. I saying thank you so much, Daktari. Someone else by the name Desnderio saying good presentation, madam. I like it.
Thank you.
There's someone else by the name Jerry, best occupational therapist ever. Can't get enough of this presentation. I think people are asking a lot of questions, and I'm sure they'll continue asking questions after these conversations. And one more as we're almost winding up. Maybe someone out there has a child who has maybe cerebral palsy, and maybe they're fearing, they have been hiding the child. What I've seen mostly, people hide these children. They don't want them to be seen. Oh, my child has a condition which shouldn't be seen by people, and they don't know whether this child can be helped. Can you talk to such a mother here on the camera? Tell them that all these conditions are treatable and their child can be okay again.
Especially the cerebral palsy patient. Most of the mothers hide them. Please, if you are there, you have a child who has a cerebral palsy or another condition, and you are feeling not comfortable to bring out that child, please come to us, Every Children's Hospital, and we'll be able to help that child so that the child will not come to blame you later. Please come visit us and we'll help you.
Maybe is there a possibility whereby a child has one condition? Like maybe it's only their neck which has a problem and not the hands or the legs.
Yes, there are, like for example, there are those child, for example, who comes like the child is 10 months and cannot be able to stand. That's the only problem, because there are other, we said as occupational therapists, we ensure that our child are achieving this developmental milestone well. So you find a mother comes with the child and the mother tells you, my child was studying well, but all of a sudden the child stopped. There are many things, not only this condition, there are many things which can cause a child not to study. We have another condition, we call it hypersensitivity, where a child fears the feet to be on the ground. We also, this makes the child not to study well. Unapata mtoto anakuja miguu. It is also a problem. So come and we manage it. Now that the child has a problem with studying only, and we manage it within 2 weeks, the child is able to study.
Wow. And people are staying with children at home, maybe they don't want
to. They don't know. Others are waiting. Like mothers comes and tell me, I was waiting, maybe I was thinking maybe the condition, the baby will come to study. No, please, if you detect any problem in your baby's milestone, please visit us, come and ask.
Like someone will say, you know, mine started walking with 1 year, they wait for 1 year, the child is not walking. They say, let's wait for 5 years.
That's what happens. Although nowadays I'm happy, parents are so keen, and like in our maternity unit, I always educate them on milestone. So at least nowadays, I'm happy now the patient are able to turn out in case there is problem.
So there's something you talked about, which is one of the causes of delayed milestones, which you said is malnutrition. Now, when patients like these children come to you, what are the kind of nutrition that you advise them to take so that maybe they can improve on their conditions?
Now, when a malnutrition child comes to me, now I refer them to the right person, which is nutrition. So I send them to a nutritionist. Now they are being guided on how the patient is able to, they are taken through the management of malnutrition, because there is that management of malnutrition. Now after that, now the patient will continue with the therapy. So as the patient comes for therapy, we are also following up with nutrition. And if we find there is any other issue, as I said, we have our pediatrician, we also send them to our pediatrician. And we ensure our client is covered everywhere, so that the patient can be treated well, whole and satisfied. And the patient can be satisfied.
Awesome. So would you have anything else that maybe you'd like to tell us as we are winding up regarding your department, regarding what you are doing right now?
What I would like to say is thank you to our listeners. And if you know someone, if you maybe you are not the one who has a child with this condition, maybe you know someone, please, you can go and advise and tell them to come to Able Children Hospital. We are ready to serve them, to serve our client. Yeah.
Okay, awesome. I'm very sure some of your clients and some of your friends maybe who are watching this conversation, and even if they were not watching, I know they'll watch later. And we are grateful that you have come through for the show. And everyone can get these services at TENRI Children Hospital at Majimbo from every day from 8 a.m. to 5 p.m. from Monday to Sunday. So come for these services, and your child, and even you yourself, even if you are a grown-up, you can be helped on by our occupational therapy. So we appreciate you for tuning in. You can share the conversation to your friend on all our social media platforms, and you can also continue asking all the questions that you have, and I'll be directing them to our OT so that she can be able to answer you all these questions. So thank you so much for tuning in. You can also talk to us on 0723-386-706 or 0718918189, or talk to us on all our social media platforms, and we'll appreciate. We thank you for tuning in. Keep sharing the conversation. I am your host, Washara. Thank you so much, and have a good evening.